Okay, online students, it is time for part 2 of our adventure for our diabetes lecture. And now we're going to try to understand a little bit more in depth about type 1 versus type 2, the clinical manifestations, and how to treat both types. So I hope you will enjoy the adventure. Here we go. All right, this is diabetes mellitus, part 2. And we're going to be talking about control because research supports that the key to prevention of long-term complications in diabetes is keeping those blood sugars and cholesterol levels as close to normal as possible. It's kind of like doing the hokey pokey, and that's what it's all about. That is what it's all about with diabetics. Now, that's easier said than done. Keep your blood sugar level in control and keep your cholesterol levels in control. Bye, see you later. That takes everyone on board for that to happen. Because if you've got a mother who's been diagnosed with diabetes and she's going home and having to cook for 3 or 4 children, and sometimes you know how it is. You're the last one to take care of yourselves. And when you are that, then you've taken care of everyone else. Sometimes you find yourself eating things and not having time to do that exercise that you should be doing. So it's real easy to say you should do this without realizing that there may be some other factors involved. Etiology. Type 1 was formerly called insulin-dependent diabetes mellitus, or IDDM, also known as juvenile onset, because mainly this type used to occur in our younger children. Again, if you remember back, I said the peak age was 10 to 15 years of old. Now, what happens here is there's a destruction of beta cells, and it occurs because of different things. It's thought mainly, but not proven to be, an autoimmune destruction. And why do we think it's that? Because if you go back and look, we say with type 1, you see autoantibodies present. Now, remember I said also that HLA typing had to be a big factor in type 1 diabetes. The HLAs have a very strong association with type 1, particularly if you had the following HLAs, the DR3, the DR4, and the DQ. Now, the HLA-DR2 actually protects against diabetes type 1. So if you happen to have the 3 and the 4, you're set up for it. But if you happen to have the 2, you're more likely to be protected against it. So just depending upon your genetic makeup itself and being in the presence of certain viruses triggers this autoimmunity where we have total destruction of those beta cells. There can also be genetic defects of the beta cells. Most of the time, though, viral destruction. Now, the viruses that can cause that is like your CMV or cytomegaloviruses, your Epstein-Barr viruses, your mumps, and hepatitis. All of those have been known to be triggers, particularly in children, younger children. Because what happens is that virus will attack the islet cells of the pancreas and render them useless for producing insulin. And for some reason, especially in younger children that have these certain HLA types, it leads to type 1 diabetes. Now, in children, if you have one of these markers, let's say you just had HLA-DR3, but you didn't have the DR4 or the DQ, then you're still 2 to 3 times at risk for getting type 1. But if you have 2 of these markers, let's say you had DR3 and DR4, then you are 7 to 10 times more likely of getting the risk. If you have all 3, then you're moving up to about 15 to 20 times the risk. So the more of these that you have, the more risk you also have of developing type 1. So let's look at type 2. Obesity-dependent diabetes is what it's being called, or diabesity, because you take diabetes plus obesity, and the new term is diabesity. So type 2's obesity is your biggest risk factor. Type 2 now was formerly called non-insulin dependent diabetes mellitus. 90% of people with diabetes have type 2. Only 10% have type 1. So this by far is the most common type of diabetes. Now with this type of diabetes, viruses and HLA typing do not appear to play a role in the development. but heredity does. There is a strong genetic component, but there's no HLA correlation. So there's a familial tendency with type 1, not genetic, but with this one, it's more of that genetic component. It's increased among your Native Americans, African Americans, and Hispanics as compared to Caucasians. Part of that has to do with dietary habits, as well as some other risk factors. Because the main thing is obesity, diabetes. Obesity decreases, we know, insulin receptors in the tissue, and that leads to insulin resistance. Now, when you think of the word obesity, that means more than 20% above ideal weight. And when you're usually 20% above ideal weight, you tend to eat a little more. When you eat more, you need more insulin to metabolize that glucose. Well, after a while, your body just can't keep up with the demand. And as you age anyways, insulin resistance increases. So in other words, there's no supply for the high demand as you continue on your trip of growing older and having decreased insulin receptors. Now, if you think about the lock and key system, which is the way most of our stuff works in our body, usually there is a receptor that goes into the cell that locks in there, and lets the insulin do what it needs to do. It transports the glucose into the cell. Well, with the insulin resistance is what happens as you get obese, that cell itself becomes disjointed or disfigured, distorted a little bit, so that lock and key system don't fit just quite as well as it used to. It's kind of like jamming a door and you can't get the key in real good anymore. And because of that, then that insulin can't take that glucose into the cell like it normally does. So as you lose weight, though, if you lose a lot of weight, a lot of the reasons a lot of diabetics are able to get off of their medications and some other things is because you tend sometimes to reconfigure or go back to that figure as it was in the lock and key system so that it fits again. As far as why is diabetes occurring more frequently? Well, let's think about that. Number one, we're living longer. Obesity itself is increasing. Most of us have a fast food craze, whether it be because of time restraints or other issues. Fast food is a craze, and the all you can eat, the better it is, right? Sedentary lifestyles. So there are all kinds of reasons in today's society that we are seeing more and more diabetes. Now we know there is an interaction between genes and the environment. We know that genes load the gun, and your environment is what helps pull the trigger. So in other words, what I'm trying to say there is that you can be set up to have diabetes. You can be genetically vulnerable to it. But if you change your habits early on, if you are exercising, if you're watching your weight, if you're keeping things in control, you can head off that type 2 diabetes. But if you let your environment go to where you're eating whatever you want to, you have a sedentary lifestyle, you become obese, then you're setting up your environment to pull that trigger. Incidence. They're saying now that there's about 25.8 million Americans living with diabetes. And like I said, type 2 now, which is the most common, is the one that comes on slowly. So actually, there's a whole lot of pre-diabetics out there that have not been diagnosed as diabetics at this time. So that number is actually much, much higher. 300,000 die yearly of complications. 1 million new cases every year in the United States. That's staggering if you think about the cost of diabetes then. And we're also, unfortunately, seeing an increase in children diagnosed now at the age of 4 with type 2 diabetes. And would you like to guess why? What's the number one risk factor? Obesity. You got it. So the predictions is in the next 4 decades, we're going to have an increase of 165% in diabetes. So what's that tell us? We're going to have very educated nurses. We're going to have diabetic educators out there. And we're going to have to be dealing with this because right now, diabetes is the 7th leading cause of death in the United States. So you can imagine if we keep tenfolding this number who have it, that number is going to increase as the number of deaths is going to move on up the chart. So who should be screened? Well, screening. Screening is secondary. Anytime I talk about screening, secondary level of prevention. So who should be screened? All individuals greater than 45, especially if their BMI is greater than 25. How should they be screened? They should be tested with a fasting plasma glucose. Children who are overweight, BMIs greater than the 85th percentile, that have other risk factors such as a family history. They belong to one of those races that we talked about that have a higher risk, or that they actually have conditions that are associated with insulin resistance, such as maternal history of diabetes or gestational diabetes mellitus, particularly if that mom had insulin-dependent gestational diabetes mellitus. When should they start? At around age 10. And what should they be tested with? Fasting plasma glucose. So these are the screening guidelines to detect diabetes. Yes, screening, secondary. Now, who's at risk mainly for heart disease and diabetes? Is it your pears or is it your apples? Well, if you think about it, the apples are. These would be the ones who are shaped more like an apple, who have more of the abdominal fat, because all that fat lays there on top. Whereas with the other type, it's more in the gluteal or the femoral fat. You get real hippie, so you don't tend to see that as much. Someone who walks in the door that's an apple is more likely to have heart disease and diabetes than someone who walks in the door and is shaped more like a pear. Now, the bad thing is that if you happen to be an apple, you've got that more abdominal fat, it's harder to lose the weight that you need to lose. So a SCAT versus a VAT. SCAT, what do I mean by SCAT? Subcutaneous adipose tissue. What do I mean by VAT? Visceral adipose tissue. So SCAT would be fat located immediately beneath the skin. A VAT is fat located in the body cavity beneath the abdominal muscle. So you can see there, the deeper that is, the harder that it is. So if you think about the pear shape and the apple shape, most of the time, with this one just being beneath the skin and more in your hip areas, a lot of times these are your pear shapes. Now, I call the SCATs jelly bellies, because it's the people who can pick up their jelly belly and just wiggle it like Santa. Your VATs are more like those people that you go to fill their belly, you think, oh, you got a big belly, and you touch it and it's rock hard. You can bounce a quarter off of it because the fat lays below that abdominal muscle. So that is even more at risk. So not only are you more at risk if you're apple-shaped, you're more at risk also if you're apple-shaped and you happen to be a VAT, which is that visceral cavity beneath that abdominal muscle being very hard. Okay. So the pears are primarily the SCATs. The apples can be the SCATs or the VATs, depending. Okay. Other risk factors. There's something out there called metabolic syndrome, and it talks about this on page 1420 in your book. You can read up on it. Metabolic syndrome is not a disease. It is a collection of health problems, and what it does is set you up for diabetes to occur. When we think about metabolic syndrome, this is also called syndrome X. So if you hear the word syndrome X, metabolic syndrome, it's talking about risk factors. And it's talking about risk factors setting someone up, particularly for diabetes. So if you look there at abdominal obesity, and if you look on your book on page 1420 and 1421, 1420 and 1421, on top of page 1421, it goes over the parameters of what we're talking about here. So when we're talking about abdominal obesity at the top, we're talking about waist circumference of 40 inches or more for men and 35 inches or more for women. Triglycerides, we're talking about 150 milligrams per deciliter or more, or you're having an HDL cholesterol less than 40 for men and less than 50 for women. So your HDL cholesterol would be less than 40 for men and less than 50 for women. And again, these parameters are on page 1421 in your book. Hypertension. They consider this a risk factor if your blood pressure is running greater than 130 over 85. 130 over 85. And that is whether you are or not on drug treatment. So even if you're on hypertensive and you're still running greater than 130 over 85, it's a risk factor. Fasting blood sugar level would be greater than 110 is the main thing that most people are going by. Now, I will tell you that a lot of people are saying greater than 100 now. So really, you're considered at risk if it's running greater than that. So for test purposes, we are going to go by the book, and it says an elevated fasting glucose greater than 100 puts you at a risk factor. So abdominal obesity, check. Triglycerides, check. HDL cholesterol, less than 50, check. Hypertension, check. Fasting elevated glucose greater than 100, check. I believe I have metabolic syndrome. Most diabetics, a lot of them that have the obesity factor, the true obesity factor, have metabolic syndrome. So one of the things, if you think someone is headed to headed for type 2 diabetes, is to check how many risk factors they have in this cascade and the metabolic syndrome. Diagnostic criteria for diabetes. How do you diagnose someone with diabetes? Well, they have to have these 3 things. Fasting plasma glucose greater than 126. Now, that's someone who comes in who's been fasting for 8 hours and it shows up as greater than 126. And that's more than one occasion. You can't just do it because of one occasion. So you would have to have done it on 2 or more occasions. Number 2, a random plasma glucose greater than 200. That means anytime I just randomly check my glucose and it's greater than 200. An oral glucose tolerance test. That's what pregnant women have to take, where they go in and drink that the 75-gram dose, and they go back and have their blood drawn every so often to see if their sugar's dropping back down. And at the end of that 2-hour sample, it's supposed to be below 200. Well, if you did an oral glucose tolerance test, it would continue to be greater than 200 at the end of the 2-hour sample. If they have a hemoglobin A1C that's running 6.5 or greater, then usually that's indicative of diabetes. Now, what about these people we used to call borderliners, or pre-diabetics? Now they're called impaired glucose tolerance folks, IGTs. And they're the ones who have a fasting plasma glucose anywhere between 110 and 126, a 2-hour greater than 140 but less than 200. So if we have someone that we know that's coming in here that's in this borderline group, what should we be doing? Teaching, 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 educating, educating, educating. And the reason why is that 25% will convert to type 2 within 10 years of being a borderliner if they do not change their habits. Very important. Glycolated hemoglobin, or hemoglobin A1C, I have nicknamed the tattleteller because it tattletales on you. My grandmother, God rest her soul, bless her heart, she was very, 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 very non-compliant. But what she would do before they had hemoglobin A1Cs is about the weekend before that it was time for her to go to doctor on Monday, she would do real good. She would straighten up. She'd be taking her medicines. She'd give herself a little extra dose of insulin before she went, so that when the time they did their fasting plasma glucose on her, it looked like she was being pretty compliant. Now, when they came up with this, and they were doing it over an average of what your blood sugar had been for previous 3 months, she couldn't do that anymore. So needless to say, she did not like it when hemoglobin A1Cs came along. Hemoglobin, we know, is a protein in the white red blood cells that carries oxygen to your tissues. And if you remember back in hematology, a red blood cell itself lives for about 120 days. So that's why we can draw it every 3 months and get an accurate reading, because of the lifespan of that red blood cell. So normal results are between 4 and 6% in a non-diabetic person. If you're diabetic, then it's considered if you're greater than 6.5%. Now, if you are a diabetic, then the goal is to keep you below 7% or below to be compliant. There are some things that can mess with that. Anemia can cause falsely positive levels. blood transfusions. If you get a blood transfusion, that could affect their results. So there are some things. Now, you want to monitor your hemoglobin A1C about 3 to 4 times a year, usually about every 3 months they have you come in and draw it. And they have come up with a testing hemoglobin A1C at home that has also been approved by FDA. It's easy to use. It requires no strips or maintenance, and it's fairly accurate. So that is something that is available as well now. Now, just a comparison of hemoglobin A1C to blood sugar readings. Here's the reason they want it lower than 7. Because if you've been running about 7%, then your sugars have been averaging about 154. And really, that's pretty high. If you're averaging 6%, then your sugars have been running about 126. So you can see that if you're running 6.5, then you're kind of somewhere in the middle here in the 130s. 8%, 183. 9%, you're running about 212. 10%, 240. 11%, 269. 12%, 298. And over that, you're getting into the 300s. So you have to be very, very careful. Now, for a long time, it was okay to be at 7, but now they're saying, no, we're backing that down because now we think you're, as far as diagnosis, now 6.5 because they're saying that the closer you are to 7 and above, the more at risk you are for cardiovascular risk and disease. So now that's why that they're diagnosing people at 6.5 instead of 7 because they want to catch them early enough to try to prevent some of these cardiac sequelae. So what's new in blood glucose meters? Oh my goodness, have they come a long way. They almost look like the bag phone did years ago. They are simpler to use. They provide results very quick. Most of them can be done in just a matter of seconds. Most of them have made it very easy to collect blood, and they made you quit having to do all of that coding. Most of them are very portable, have a large memory span, and only require a very small drop of blood. And they save your data. One of the things they are looking at to have non-invasive blood sugar readings, which would be ideal for diabetics because they hate getting their fingers prodded over and over, or their alternative sites even, because now we can use, we know, the forearm. What they're looking at is a non-invasive device that you simply insert your finger into a probe similar to a pulse ox, and that it would read it. Now, we have not come up with that and perfected it yet, but that is one of the things they are working on. So let's look at the clinical manifestations for type 1. Signs and symptoms come on abruptly. Remember, it's the 3 Ps: polydipsia, polyuria, and polyphagia, fatigue, and weight loss. Why are we having those signs and symptoms? Well, we're having the polyuria because of osmotic diuresis. If you think about the amount of glucose filtered by the kidneys, it's exceeding what's absorbed. So you get a larger concentration down there. So you start pulling, and you start pulling extra fluids off. Polyphasia, because of the depletion of those cellular stores of your carbs and your fats and your proteins, that causes that cell to starve. And polydipsia because those high blood sugar levels, again, lead to osmotic diuresis. So because of intracellular dehydration, that stimulates thirst. Weight loss because of the osmotic diuresis and the loss of body tissue. So what continues to happen if we don't have some glucose on board? Well, our protein and fat is going to break down. Once that breaks down because of the lack of insulin, that results in weight loss. The fats break down and increase the production of ketone bodies. Those are byproducts of fat metabolism. Ketone bodies, we know, disturb that acid-base imbalance because now we got more acids than we should have in the body. That's going to lead to metabolic acidosis and DKA in type 1. We know that fats are not a good thing to use for fuel, and when we do, lipid levels increase. Actually, it can be as much as 5 times the normal amount. With type 2, the clinical manifestations are a little different. We don't necessarily see the 3 Ps. And instead of seeing DKA, we see what's called HHNK or HHNS. Hyperglycemic, hyperosmotic, non-ketotic syndrome, or coma. Recurrent infections and delayed healings. Genital pruritus or itching, because if you think about it, all that glucose has got to go somewhere, and sometimes you can only filter so much. The kidneys itself is set up in the renal tubule system that once you get over 180, that's all it can absorb. So it just starts spilling out that extra glucose in the urine. Well, when it does, that bacteria just fly there, and the candida infections and the yeast, because it just thrives in that environment. Visual changes, blurred visions, neuropathy, fatigue, obesity, hypertension, and again, remember this one occurred usually over the age of 30 with a peak incident in your 50s. So if you're taking care of an adolescent who's got who is potentially a type 2 diabetic, and they keep saying, man, I just keep getting recurrent vaginal infections, UTIs, I don't know what's going on. Sometimes that's a red flag to get their sugar checked, just that in itself. There's other forms too. Can be caused from pancreatic disease, where you actually injure the pancreas and the beta cells are destructed. Some chemicals we know can destruct it, and some genetic things such as Turner's and gestational diabetes can lead to type 2. Now, let's talk about treatment for type 1. Insulin replacement is required. There is no average dose. It isn't like, okay, you come in and we're going to start everyone on 10 units of this and 20 units of this. It doesn't work that way. Every individual's different. Every individual's going to require a different dose. Unfortunately, there is no cure for diabetes. So our overall goal has got to be to regulate and control glucose levels rather than cure them. Insulin replacement is required. There's no average dose, like I said. And what we've been using is exogenous insulin, and we've had that since 1922. Now we primarily use the human insulin. It is the insulin of choice. There are different strengths. There's U30, U40, U50, U80, U100, and U500. U100 insulin is almost always the one used in the U.S., indicating that for each meal contained, there's 100 units of insulin in that syringe. Now, you want to be very careful that you're using the correct syringe. Unfortunately, the #1 medication error out there right now is insulin administration. And the #1 thing is giving too much. People think they're giving 10 units and they're giving 100 the whole syringe. Insulin is broken down by gastric enzymes. That's why we cannot give it orally. Now, I know these amounts differ slightly from page 1432 in your book, but I want you to go by this table for exam purposes. And there will be lots of questions on this, so know this, inside, outside, upside down. Rapid acting, Apidra, your Novolog, your Humalog, the onset is 5 to 15 minutes with a peak in 30 to 90 minutes and duration 3 to 4 hours. With your short acting, it's Humulin R, Novolin R. This one peaks in onset of 30 minutes. It peaks in 2 to 4 with a duration of 3 to 6. Now let's look at the difference between rapid and short acting at the onset. 5 to 15 minutes versus 30. So what's that tell us? That tells us with a rapid acting, we're going to have to dose and eat. Dose and eat. You're going to have to eat within 15 minutes of taking that, or you're going to have a hypoglycemic reaction. Where with the short acting, you really need to take it about 30 minutes prior to eating, because that's when it's going to kick in. So dose and eat with the rapid acting about 30 minutes before your meal with the short acting. You can see there also, if you were to look at the color of those, they are clear. Both of those are clear. Your intermediate acting, or NPH, Novolin N, Humulin N, these are cloudy. You can see there the onset is 1.5 to 2 hours, the peak is 6 to 12, and duration is up to 16 hours. Your long acting, which is your Ultralental, your Lantus, your Levemir, these are clear as well. So it used to be we didn't have the very long acting, and you could pretty much, okay, we pretty much had the short acting and the intermediate, so you kind of got the clear and the cloudy down pat. But now that we've got the rapid acting and the ultra long acting that are both clear as well, you have to be very careful that you're giving the right dose and the right insulin. The onset is 2 to 6 hours. There is no peak, and duration is 24 hours plus. Now with Lantus, we cannot mix it with anything. We do not mix it with anything, okay? Also, you have to be very careful because once you give it, it's going to be on board for about 24 hours. Okay? So make sure that you understand this chart and that you memorize it. So here's an example of something I might ask. The RN is teaching a 15-year-old client about the different types of insulin. The patient takes NPH insulin at 8 a.m. So you go to your NPH, that is your intermediate acting. She just took it at 8 a.m. The RN interprets that the adolescent understands this type of insulin when the child states that the most likely time for a reaction. Well, when would they react? When it's peaking. When does it peak? In 6 to 12 hours. So if she took it at 8 a.m., then we're for about 2-ish, 3-ish, we're worried about, it's going to be peaking in that 6 to 12 hour period. So what would it be while she's working out at 9 a.m., while she's taking a test at 10 a.m., while she's eating lunch at noon, or while she's golfing after school at 3? And it should be D, because insulin NPH peaks in 6 to 12 hours. So that's the kind of questions I'll ask over that chart. Combination insulins are also out there, Humulin 70/30, NPH 70%, and regular 30%. Humalog 75/25 would be Humalog 25%, and then a suspension of MPL, which is very similar to NPH. The only kind of insulin giving IV would be your short-acting, your regular is giving IV, even though now we are starting to see some of our rapid-acting also put in some of the pumps. The proper way to verify with another nurse, this is very important to know. So the kind that's given is regular, short-acting. The proper way to verify with another nurse, okay, you're on the floor, someone walks up to you and says, I want you to verify this insulin with me. And they show you the insulin syringe. Should you say, okay, because it looks like there's 20 units and it's clear, and they tell you that it's regular? No. Why? You have no idea if it's really regular. Maybe they drew up the Rapid. Maybe they drew up the Lantus. So the best and safest way to always verify it is to actually see that syringe inside that valve that shows which insulin it's coming from with it drawn up before you actually okay it. Some fast facts about insulin. Insulin in use may be at room temperature up to 4 weeks. All your other insulin should be refrigerated. With mixing, you want to inject it immediately. If it's your lentil, ultra lentil, again, your Lantus cannot be mixed with anything. Do not aspirate now. With almost all your stuff, they're saying don't aspirate anymore because of the pain. Hold pressure after injection, but do not massage because that's going to affect the metabolism of that insulin if you do. Most insulins now are given on sliding scales, and they're giving in their low, intermediate, and high doses. ICU have drips that are a lot, and you just pretty much read the scale on those insulin, on the sliding scale insulins. So in other words, if you went to look at the scale and their sugar was 250 and they were on a medium intermediate dose and it said under the intermediate column to give 4 units, then you would give 4 units. You just read, all you do is simply read, make sure you're in the right one, the low, intermediate, or high dose, and that you just read across there and figure out how much to give. What about mixing 2 insulins? Let's say we've got some NPH and regular. Well, first you're going to rotate or roll the NPH or intermediate or long-acting. Then you're going to draw back the amount of air into the syringe that equals the total dose. So let's say you're giving a total of 35 units. You would inject that air equal to the intermediate or the long-acting into that valve, and then you would eject air equal to that into the regular valve. And then you would withdraw the regular first. It's always clear to cloudy. And then you would withdraw the intermediate. So you put the amount of air you're going to need in them, then you would always draw clear to cloudy, clear to cloudy, clear to cloudy. There are some controversies out there. Do you go 45 degrees or do you go 90 degrees? Well, the answer is depends. Depends upon the amount of subcutaneous tissue, depends upon the age, depends upon their size. So if it's a very thin person, then yeah, you're probably going to want to go at a 45-degree angle. If it's a very obese person, then you're probably going to go at a 90-degree angle. Use of alcohol pads. We now have proven that soap and water are just as good. The key is make sure you dry it off. Whether you're using alcohol, make sure it's dry completely, or soap and water. So make sure you're using something that has been dried off. The use of the same syringe. Research supports that insulin preparations have bacterial additives that actually inhibit the growth of bacteria that's found on your skin. But one of the things you want to make sure you're doing is disregarding that if it's dull, bent, or contaminated. Well, it's really hard to see if that end of that is dull or bent unless you actually have it under a microscope. My grandmother was one of those who did not believe in using a syringe one time and throwing it away. She thought that was very wasteful. So she would use it several times. Well, she didn't realize the end of that was bending every time, so that by the time she used it the 5th or 6th time, that it was actually causing skin tears because it wasn't as sharp, it was dull, and it was hurting more. So after about, 2 times, it really starts bending. Disposable of needles. How do we dispose of those? That has been a sore spot for a long time. Community programs have gotten together to develop some things. SafeNeedleDisposable.org is one place you can go to, but a lot of people just put them in their coffee cans, put the lid on, throw them in the trash, take them to they are taken to the dumpster, and then people are out there syringe diving, looking for syringes that they can use, particularly some of your people with habits will want that. So you have to be very careful. It is very hard, and it's one of those things we have not come up with a good solution yet. Rotation of sites. Rotation of sites. Now, used to would be that you just rotated, you went from the arm to the leg to the belly to the arm to the leg to the belly. They don't say do that anymore. Part of that's because of the erratic insulin absorption. So now they say rotate within an area for a while. So if you're in your arm, you want to rotate in that arm for a while. Then you want to move to a new area. And they say by rotating in that arm, you want to give about 4 to 6 injections in that one area, about 1 inch apart. Then move to your belly. Then give, again, 4 to 6 injections about 1 inch apart. And it has to be 2 inches from around the navel area. And remember, peak times are going to differ if you give them in different locations. So if you've been giving them in the arm, then you switch to the abdomen. One of the things they need to keep in mind is that it's going to peak a little bit different. So what are the absorption sites? Well, in the abdomen, it is the fastest but the shortest duration. In the arm, it's pretty fast but has a shorter duration. In the thigh, it has very slow onset but a longer duration. And the buttocks is the slowest but also the longest duration. So think about what you're going to be doing for the day. For example, if you're going to be exercising before you choose your site, then you want to think about that because that's going to affect the rate and absorption of where you put it. So if you're going to be out running, you might want to put it in your arms versus your legs. Regardless of what you do, if you're going to go exercise right after taking the insulin, you always want to watch for hypoglycemia. Hypoglycemia. One of the things that have come out is insulin pumps, also known as continuous subcutaneous insulin infusions. Who's a candidate? Well, a candidate is those getting multiple daily injections without results. Those getting multiple daily injections without results, particularly someone whose hemoglobin A1C is staying above 7%. What it does is mimic a normal function pancreas, but can't detect or respond to changes in blood sugars. So one of the newer things, though, that has come out, your newer machines, is that they actually have a monitor or a sensor in the skin that helps read those blood sugars. If you look on page 1429, it will show you an insulin pump on one side and then a glucose sensor that's been implanted in the other that is sending signals to the actual machine, and it is picking up on the actual glucose level. So some of the newer machines do have it where you can actually put in the glucose monitor. Most of them, though, a lot of people still have the machine that have to still check their sugars with the machine because they only have the insulin pump itself. Now, the pump can be internal or external, and there is a good picture of it on page 1433. And if you've never seen one of those, I would encourage you to YouTube continuous subcutaneous insulin infusion pumps and watch a YouTube on it. It is small with a 3 ml syringe. It delivers continuous sub-Q insulin at a pre-programmed dose into the abdomen. What you're going to have to do is change that needle and rotate sites about every 48 to 72 hours. It uses regular insulin for the most part. Some of the newer ones are using the rapid. And it gives you that basal rate. So, just like I said earlier, your body's continually going through there and about every 10 minutes giving a basal rate so that you end up with about 40 to 50 units a day. Well, that's what this machine's doing. It's acting just like a pancreas. And you have it preset for a basal rate. But what happens when you eat? Well, when you eat, just like the body has to increase that insulin production, you're going to have to do it through the machine. So you're going to have to bolus yourself. So what they will do is count up their carbs, and based upon the amount of carbs they have eaten, they will give themselves a bolus with that meal. It is very costly. Most of your insurance are paying for it, though, because it is helping control and keep down long-term complications. These have been around since about the 70s. Bolusing depends upon, again, I said your carb intake. Usually for an adult, the carb ratio is 1 to 15. So for every 15 grams of carb, you're going to give yourself 1 unit of insulin. For a child, it can be 1 to 15 to 20. So 1 to 15 to 20 grams. So if you're an adult and you just had a meal that had 60 grams of carbs in it, how much would you bolus yourself with insulin? Well, it's a 1 to 15 ratio. They're 16 grams, so it should be 4 units you would bolus yourself with. The advantages and disadvantages, it does, again, help with glucose control. It's very small. They're making waterproof models. It does eliminate insulin injections. It's for the most part, very accurate. And it improves hemoglobin A1C levels and can be used for even young children. The disadvantage, again, is it's expensive. It can malfunction. Those tubes can get kinked. If they get kinked, you're not getting insulin. If you're not getting insulin, your sugar's going to rise. They can come apart, and you may not get the insulin. So any machine you have is not foolproof. Something can happen. So you want to make sure that they are monitoring their blood sugars frequently. Most of them don't need to be removed more than 1 to 2 hours, and they can cause some irritation. So motivation is the key here. They also have pre-filled syringes, like your Nova pens. Puncture is automatic. It's convenient, easy to use, and it uses a very small needle, 8 to 12 millimeters. So therefore, you have a decrease in pain with the injections. Now, in Europe, 95% of clients with diabetes use the pen as compared to only 5% in the U.S. Why? Well, if you think about it, in Europe, instead of going to their general practitioners, which is what most of the diabetics do over here, they go to diabetic specialists, and they have also socialized medicine in their system. So those are the main 2 reasons. They see diabetic specialists who are more familiar with the pens, and they have socialized medicine system. Now, it doesn't allow for mixing. The maximum dose is 80 units at one time that you can give with the pen. Has a storage. It is stable for about 7 to 30 days once it's open. And cost reimbursement varies with the pen. As far as treatment for type 2, the emphasis is on medical management in type 2. Diabetes focuses on blood sugar, lipids, and blood pressure. So we are going to do diet, meds, and exercise. Now, that didn't just say meds. You just can't take a metformin and go out and eat 3 Dairy Queen Blizzards, okay? It's kind of like going to Big Mac with a Crestal in your hand. You've got to do stuff in moderation, and the diet and exercise is part of the plan, not just the medication administration. The use of oral hypoglycemic agents are meant to supplement, not replace. So targets for oral hypoglycemic meds, if you have a type 2 diabetic who's on oral hypoglycemic agents, you really want their fasting between 90 and 130. You want their postprandial blood sugars, which means you've taken it 2 hours after they eat, less than 180. And you want their hemoglobin A1C less than 7%. This can tell you that the type 2 diabetic is doing well on their oral hypoglycemic agent. So diabetes management is monitoring your ABCs. But in this case, your ABCs stand for something a little different. Your A stands for hemoglobin A1C, glycemic control. Your B stands for blood pressure, and your C stands for cortisol, or your lipid levels. So your ABCs. Your oral hypoglycemic agents are your first generation sulfonylureas. These are your long-acting 24-hour ones. Now, these are our oldest class of drugs that we don't use these as much because there's newer drugs out there with fewer side effects. We do have to use them with caution because they can cause hypoglycemia. Also, you have to use in caution with people with liver and kidney problems because they're metabolized and excreted in the kidneys and the liver. The main side effects are GI disturbances, rash, nausea, fullness, heartburn, and hypoglycemia. The big thing you want to remember with these is take them with food, and they can cause weight gain. Will someone want to take these that's going to cause weight gain that's already obese? Probably not. So how does a doctor figure out what generation or what agent to put, oral hypoglycemic agent, to put a patient on? They look at a lot of things. They look at the cost, the age, the response. Do they have a history of kidney and liver problems? So they have to look at several things before they decide which meds to put them on. So some examples would be like your Oronase or Diabinase, and some of you have never even seen these because they're an older generation. But again, you have to take them with food at breakfast, These are long-acting. Most durations last up to 24 hours. Diabinase, however, can last up to 72 hours. Do you see any implication for the RN? Absolutely. To give someone Diabinase, you better be watching their blood sugar very carefully. And like I said, we don't hardly give that anymore. Second generation sulfonylureas came along and replaced the first ones. They are basically have the same action and caution. They are a little more expensive, but they don't have as many side effects and interactions. I call these our G's because if you look down through there, everything starts with a G. Now on the test, I will give you both the trade name and the generic name, so regardless of which one that you learn, you will have it. Your glucotrol, you take a half hour before meals, where with the Micronase and the Emerald, you take with food. So the glucotrol is the one that's a little bit different. So if you see a G word, you probably want to pick it if you're picking second generation sulfonylureas. Hint, hint, hint. Your raguanidines are your intermediate acting. These reduce hepatic glucose production and they boost sensitivity in the muscle fat and liver. The bonus for these are that they decrease triglyceride levels. They're not metabolized by the liver and they're excreted by the kidneys. So they're good for clients who have significant obesity. Check. Renal insufficiency leads to lactic acidosis, so you have to be very careful that they have very good functioning renal system. Side effect is diarrhea, particularly when they very first start taking this. This is your metformin. This is a drug of choice. It is very common to give metformin anymore. The diarrhea usually subsides after they've been on it for a while, but when they first get on it, you want to warn them, be close to a bathroom. Up to about 24 hours duration, it can cause some drowsiness and upset stomach. Your alpha-glucoside inhibitors are your starch blockers. These facilitate insulin's actions on the peripheral receptor cells and interfere with the absorption of carbs. They actually delay the absorption of them, so they do excrete it more. The big thing your alpha-glucoside inhibitors do is work on this postprandial blood sugar. They work on this postprandial blood sugar. So if you're having someone who can't keep their 2-hour blood sugar below the 180 goal, then one of the things you may want to consider is giving them an alpha-glucoside inhibitor. They do cause a lot of gas and diarrhea, so be close to the bathroom. This would be like your Precautions and Glycet, and they last up to about 8 hours. Your TZDs are your increased receptor sensitivity to insulin. They're metabolized in the liver. One of the things they do is decrease lipid levels. Now, they are excreted, though, in the feces with this one. They can cause flu-like symptoms, headache, anemia. Fluid retention is a big thing with these, and weight gain. So if you've got a client with CHF, this would not be the drug of choice. If you had a client with CHF, this would not be the drug of choice. You can give it with food. This will be your Actose, I can't get it out right now. Sometimes the words just won't come. One of the faculty was recently on this medication, and she started having a whole lot of swelling, a shortness of breath, and part of it was because of these side effects. It does control your sugar well, but these side effects can be very scary. So you really want to watch someone who's already a little overweight and has trouble with fluid retention. Again, particularly your CHFers. You would never want to give them the Actose. Some of your analogs increase insulin secretion and prevent postprandial blood sugars. Your Starlex, you want to take these about 30 minutes before meals. You want to omit the drug if skipping a meal and watch for hypoglycemia. You don't see these as much. Some of your newer meds that you're going to see is your DD4 inhibitors, your Januvia and Onglyza. These are work by blocking the DD4 inhibitors and then therefore enhancing the body's ability to control blood sugar levels. They're not associated with weight gain. They don't cause a significant drop in sugar, so you don't have to watch about hypoglycemia as much. But you do want to watch them for Stevens-Johnson syndrome. And if all else fails, we can order combos. Now, one of the things you have to watch for with Januvia and Onglyza is that it can cause pancreatitis. These can cause pancreatitis. So abdominal pain, nausea, vomiting, you want to make sure that you are watching patients for that very much so. Two of the newer drugs that are out there right now is your Invokana and your Farxiga. Invokana and Farxiga work a little bit different. The Invokana and the Farxiga work by working on the kidneys and excreting more of the glucose through the urine system. Remember I told you the threshold was about 180. Well, it drops that threshold and you excrete more and more of that glucose. Well, you can imagine if you excrete more and more of that glucose, what your number one side effect is going to be: UTIs. Urinary tract infection, yeast infections. You're going to have yeast infections out the wazoo. So a lot of people get some good doses of diflucan to help with that. It also increases, it can help you urinate a whole lot. So if you're urinating a lot, you have to watch for dehydration. It also can help control the blood sugar, blood pressure a little bit better. Some people have complained of dizziness while they're on that because of the decrease in that. But one of the things that's out there right now that you have to watch about is that it increases cholesterol levels. Well, if you've already got a person who's got trouble with cholesterol levels and you put them on this, then it can cause problems with that increase. So you put someone on Invokana, you're going to have to watch their cholesterol levels very, very carefully. One of the newer things that they've come out with now, too, is even with type 2 diabetes, Invokana is putting a lot of people with type 2 diabetes in DKA, which is really not supposed to happen, with blood sugars as little as 250 or higher. So because of that, there are some FDA concerns right now, and they're watching the Invokana and Farxiga. Overall precautions with any oral hypoglycemic agent would be caution with clients with kidney disease, caution with clients with liver problems, it's excreted in the feces, watch for allergies to sulfonamides. Alcohol with oral hypoglycemic agents can cause antabuse-like effects. That's where you get that extreme vomiting. Watch for interactions with other drugs like steroids. We know steroids increases the blood sugars. And know that the duration is going to vary depending upon which one that you're on. The blood sugar mnemonic that you need to remember is hot and dry, sugar's high. Cold and clammy, you need some candy. That's the end of part 2. Thank you very much and have a great day. If you have any questions or concerns, please get with me. Thank you.